Thank you.
Finally, welcome to this seminar session. We have the honor to present Professor Karina Aase from Stavanger, Norway. She's an engineer by training and has been working in safety matters also in oil industry and in air traffic industry, and then moved to patient safety work, and she's gonna tell us about perspectives and status of patient safety work in Norwegian hospitals. Please.
Thank you very much. Finally, I'd love to talk to you, and I'd love to talk to those who are not in the room. So hello to you as well. Hopefully you are there and you can see the screen and hear the sound. As you might see, I've put the quality concept in brackets, and you might understand why I did that, but I will come back to that. I guess now I hope we have around 45 minutes together, and I think that we should take the questions or reflections as we go along, because it's better to take it whenever you have it in your mind. So just feel free to interrupt and say something or ask something if you want to. I come from this research group here, so I'm head of this quality and safety in healthcare systems research group in our university, and we are, since the picture is a bit old, we are now 22 researchers, and we try to be multidisciplinary. So when Risto says that I'm an engineer by training, I would rather say I'm a safety scientist by training and quite multidisciplinary. So for us it's important to have disciplines working together. So the aim of our research group is to a very broad aim to develop new knowledge, because it's a quite new research area, at least in Norway, as I think it is in your country as well. So and this is our goal, and that's why I thought I would say something about the status and perspectives internationally, very briefly, just very briefly, and then concentrate on the work in Norway, and also give you some examples from studies in hospitals that we have conducted. Okay. And concerning the title, perspectives and status, that's a difficult task. So I will not say that I have the overall view and picture of this. So it's just, I will just give you my ideas and thoughts on the issue, because it's been exploding the last 5 years, and it's difficult to follow all the literature and the research going on at the time. Okay. So first, the reason, because the reason for putting quality and patient safety together, and we also have that in the Nordic conference that you are organizing next year. We use it interchangeable together as a pair, quality and patient safety. And just to start out this presentation, it's obvious that we need to have like a picture of what this conveys, the quality and patient safety, and for whom. So do you have any suggestions? How do you use the concepts? What is safety for you, or what is quality? This is what I ask my students all the time, but we will, yeah. Elizabeth?
It's not so much a definition, but just more of a comment. Depending on your disciplinary background, your interpretation of quality and safety can be extremely different.
Exactly.
And sometimes what I've noticed in my classes, because we have different people with different backgrounds, so engineers, computer scientists, health informatics, nurses, physicians, is that it oftentimes groups, they have a presumption that the other group is thinking the same way.
Mm-hmm.
And it may not be the case.
Mm-hmm.
So there's a need to, in essence, describe what you mean in fulsome terms.
Exactly.
I don't know if you found that.
That's why I think it's fruitful to have those discussions openly, because we tend to take it for granted that we know what this is, and sometimes we don't, because we mean different things depending on who we are, and especially if you look at healthcare personnel versus patients, they will have very different explanations of what is meant by the concepts, and that's also very important to remember that patients have their own definition of quality and safety. So the most easy part in this question is for whom. Because in most of the work that we do and in this presentation, it's for the patient. Even though some might also talk about personnel safety when they talk about safety in healthcare. But since we use patient safety, for whom is the patient. But the interesting in the literature, which is coming now, is that they are establishing the link between worker safety or healthcare personnel's work environment, for instance, and patient safety. So that means that hospitals or departments or institutions with a good working environment for the healthcare personnel has a bigger chance of having better patient safety results as well. But that's a domain and an area of research that I will not go into today. So this is like the easy way out of the questions: what is quality and what is safety? And this is the definition that you are probably using in your work or in your teaching or your research, because this is the Institute of Medicine definition of quality, and it's the most used definition you can find. And there you see that the answer to the question, what is safety, is that it's part of quality, because it's the first of 6 dimensions. In fact, using the concepts quality and patient safety is a bit strange, because safety is part of quality. Okay, but still we use it for, I don't know, for practical reasons, for research reasons, because we are a bit maybe different disciplines in quality and patient safety. So we tend to use them, and also the government tend to use them side by side as a pair. But it would be more sensible to use, for instance, safe and patient-centered as a pair, because they are kind of on the same level. Yeah, and so you see that the patient-centeredness is another main dimension of quality alongside patient safety. And sometimes there are conflicts between these 6 dimensions. So for instance, number 2, effective treatment would sometimes compromise being patient-centered. So there's lots of possible conflicts between the dimensions of the quality, and also being efficient in the sense that the logistics and the patient pathways is going to be conducted in an efficient way, may also compromise patient safety or patient-centeredness. But that's a big discussion, but it was just to give you a sense of the concepts. In Norway, this is and I guess you have a similar definition in Finland as well. This is the definition that we use on patient safety in Norway. So in short, it's avoidance of adverse events. It's something that you will not want to happen. So you want to avoid the adverse events. And more specifically, the Norwegian Knowledge Center for Health Services has defined patient safety as protection of unnecessary harm as a result of health services performance or lack of performance. And that means including measures to reduce risk, processes to monitor and analyze the results, and measures to identify new risks. So this is kind of a basic definition that is launched at the governmental level. So this is the definition that the macro level uses in its white papers and regulation in Norway. And as you see, it came in 2010. So it means that it hasn't been around very long. And then we like to say that this is a new research field, but that's also debatable. At least clinicians or healthcare personnel will argue that patient safety is something that has been around always, and that to do no harm has been like the basic foundation of healthcare personnel's work. But when I say it might be a fairly new discipline, it's because research-wise it hasn't been so put on the agenda. So you all know the book that came 1999, 2000, Air is Human, which many people state as the beginning of the patient safety movement, or what they call. But before the book, what they did was that they did the record review studies. So this was the beginning of the 1990s. The Harvard medical study came with trying to estimate the amount of adverse events. So that was kind of the objective of the record reviews internationally, and the Harvard study was the first, but then there came very similar studies in the 19th and later. And then we can also see that if we look at the quite short history of patient safety internationally, you can see that there are major accidents or major incidents that kind of drive the global awareness or the international awareness of patient safety, and also drive new regulations and focus. Like, for instance, the Bristol case in the UK. From mid-80s to mid-90s had a major impact on how they focused on system failures and so on, and also more newly the mid-Staffordshire case in UK. It would take place around 2007 and 3 or 4 years. And this has changed the entire way of organizing healthcare services, for instance, in the UK. And another thing is that the WHO also is a global agenda setter, for instance, with their campaigns or their goals which very many countries adhere to or try to work towards the goals that the WHO sets. For instance, and this is just an example, but the safe surgery guidelines that has got enormous effects in many countries and in many hospitals. And if we try to look at what Elizabeth said, that it depends on who you ask, and this is like some of the perspectives that you can have to patient safety, and maybe the most dominant in the literature is the clinical perspective to patient safety, and also the I said quality improvement, but it's a bit strange to call quality improvement patient safety. More like the improvement perspective, so meaning that they want to improve something, that you introduce processes or interventions because you want to improve, and that's by far what characterizes the research area or discipline. And then you have social science perspective with sociological and psychological contributions, and of course the more technological parts, and not so much on the law part. And what is very dominant in the patient safety literature is that there is an absence of theory development. So you see all these clinical, practical studies on the amount of adverse events or the effects of different interventions, but you see very little theory development in the literature. So compared to the safety literature in general, there would be much more theoretical discussions on what is safety and different concepts and different approaches to safety would debate against each other. But in the patient safety literature, that's not very common. So if we take the clinical perspective, I already mentioned this, the record reviews. So that was like the first part of the patient safety research, was to try and establish what is the amount of adverse events. So what's the problem? And you know that this is just an example from a Canadian study, and you know that the way they do that is that they statistically select a set of journals, and then they investigate the journals for maybe triggers or try to find the number of adverse events. And then you can find in the different studies, you can find numbers like 3% of all hospital admissions, or you can find 16%. So it varies between 3 and 16% in the different studies. So some studies have said that there's a mean average is 10%. So that's kind of almost a settled number. Instead of doing your own record reviews, you can assume that 10% of hospital admissions it takes place, an adverse event takes place.
Do you have any idea why there's such a huge variation in the numbers, say from 3 to 16%? It's probably not based on true.
I don't think it's based on reality. I think it's based on the way the studies are conducted and how they do the clinical judgment of the journals, and it has to do with the quality of the journals that they select, and there's all kinds of factors that is affecting the number, I think. So yeah. So, and that's why, in my opinion, it's not very fruitful to discuss the details of the numbers. It's much better to use it as an overall indication of, okay, there's a range of adverse events here. There's enough adverse events to be able to work with this as preventive measures, or yeah. So, but it's very easy to go into the debates on the amounts or the numbers and try to criticize how it's done and can we rely on these numbers, and I'm not very interested in those discussions, because I think we should rather think of how we can proceed with
There are some poster a couple of years ago from Norway,
exactly.
where they had almost no adverse events in the hospital at all, kind of contradictory, kind of trying to prove that
Yes.
this is not a new phenomenon.
I will show you this on a slide if we have the time.
Okay.
Yeah. And then the clinical perspective is very often dominated by trying to find some evidence for different interventions. So it's about finding and validating effective safety measures, and then they just try different safety measures like leadership interventions, like crew resource management, like the safety surgery checklist, and so it's, for me as an outsider, it's the medicine. You're trying to find a medicine for this patient safety problem, and then you try the medicine, and then you try to find out whether it works or not. And very often you then set up like quasi-experimental designs. You measure baseline, and then you give the medicine, and then you measure post. And very often the results give that either you find significant reduction in mortality or some other outcome measures like adverse events, like improvement in team behavior or organizational support or something. And that's the studies that get published, because mostly if you don't find a significant measure, you don't get published. So we don't know how many studies that are there that didn't find any significant effect, but they didn't get published. But still, but there are also studies out there that gives you the results that it didn't have any effect, but there's not so many of those, and that's equally important in my view. And so, of course, if you have another perspective, like a social science perspective or something like that, you would say that this is not sufficient because you cannot reduce an intervention to be a medicine because it's not the same, and there's a gap between all the non-standardized practices that also affects the intervention. It's not possible to not include all kind of other factors that might have an influence as well. And then also in some of the studies, the time interval between the pre and post measurement is very short. So most of the studies have 3 or 6 months post measurement, and that doesn't say anything about the sustainability of the measure. So very few studies, and that is about how research projects are organized, because they are short on time most of the time, and then you have maximum 1 year post measurement is what I see in the studies. And then as one study here, you see that 85% of the the operations used the checklist. I think it was the Safe Surgery checklist during the research projects, and then it was reduced with 50% after the project ended. And this is something that, of course, we want to work towards, that this is not happening. And we know when we have research projects or improvement projects, we write a report and everything is very interesting and new, and then it just goes down, the interest, and you have to keep up the pressure to have the sustained effect. And so moving, if we go into then the social science perspective, researchers would be much more interested in describing the problem, maybe too much sometimes, because they never get around to doing something. They just love to talk about the problem. What is the problem? What does it consist of? What's the context? We need to describe the context around the practice. There's lots of organizational and cultural factors that's affecting, and also like leadership models and systems. And here's actually a Finnish report from the VTT. So they did with Teemu and Elina. Actually, Luigi is the first author, I think. Okay. And they are very concerned with what affects what. And so they would love to put up models like this with lots of arrows and complicate the picture with all kinds of factors that's affecting them. And this model here is actually a model that we have used in several research projects. And for us, it's more like a way of structuring what goes on the macro level and what goes on the meso and micro level. So it might help in some respects.
But this is something that may scare the clinicians away from
Exactly. But still, we should, some of us should try to work with this as well. And then internationally, there's also several studies, and this is actually done by the person that Henning suggested as a keynote speaker, this Bob or Robert Wachter. I don't know how you pronounce Wachter. But you can see that they at least in the US, they use this Ares human report as a baseline, and then there's studies on what has happened since the report. So you can find several studies that has in the title 5 or 10 years after what has happened, and this is of course methodologically very problematic, because how are you going to measure this development? And I don't know enough to explain how these grades were given, and I won't go into it. It's just an example of a study that has taken place. In WHO, they did a big work in 2010 on trying to establish the evidence of or the knowledge gaps related to patient safety research. And so there was a working group or an expert group, research priority setting working group was the title, and they did enormous literature searches. And they started out with trying to identify the types of adverse events and the causes of adverse events, and then to try to find out what kind of knowledge do we need to address these types and causes of adverse events. And there's this is an article that's written based on, but there's a big report available on this. And And they structured the topics according to the Dunner-Beedian structure process outcome, as you see on the left-hand side. And some of the main conclusion was that the evidence for these patient safety topics are based on industrialized countries. So the evidence or the literature evidence comes from 5 or 6 countries mostly, and there's a huge lack of research and knowledge in developing countries.
Did they talk anything about what the actual healthcare systems were like? Because one of the things I found in the health informatics literature is a lot of the research is based on the US, which, I mean, in Canada, we're very close, physically close, but our healthcare systems are entirely different. And so what is a successful outcome there is not necessarily transposable. In fact, in an odd way, I find when I come to Europe, I see things that I can easily move back and forth because of the nature of the healthcare system.
Yeah, I don't think that this group or that this piece of work did that mapping. I think the only mapping they did was that they organized it by country.
Okay.
But I know that there just came out a book in 2015 actually from the ISQA. It was based in the ISQA conference, and they kind of describes all the healthcare systems around the world. But it's more like in this country it's like this, and I don't think they discuss so much how it affects the way you prioritize or
how you run a study.
Yeah.
Because those people that go into those studies in the US are oftentimes in health maintenance organizations, which presumes a certain amount of affluence, right? The study population.
Yeah.
And as well as the physicians and nurses are specific time frame.
Yeah.
Versus what we capture in Canada as everybody.
Yeah, it's an interesting field, but I think it's highly understudied. So the other thing that they found was that there are knowledge gaps within the structural issues and the process issues that makes it hard to define the right measures or efforts. And that was like the other main result that they came with. And then if you see on the different countries, just coming back to Elizabeth's comment, it's of course difficult to say, but you can maybe say something that for instance, and this is also a report coming from this Luigi Macchi, who stayed at VTT, but he also stayed in France. I'm not sure whether he's in VTT, but this report is written by him anyway. You can maybe say that in Netherlands they are quite good on the macro level issues, that they put a lot of efforts in certification and accreditation, and all hospitals need to be accredited and have to implement the patient safety management system and stuff like that. And in the UK, they are very good on tools and measurements and also people are using the tools. Like in Norway, we also try to launch, or the government try to launch tools and steps and models, but the clinicians tend to be very reluctant towards using such tools. But whereas in the UK, the workforce is much more adherent to using the toolbox that the government lays out. In Italy, they were early with creating all these local roles like clinical risk managers and patient safety managers and stuff like that on a very dispersed and local level. So they did not use the top-down macro level approach. Australia and Canada, I would say, is also advanced in many of these areas, whereas Norway, unfortunately, is not in the front in any of these, in my view, in any of these areas. So here comes the slide that I mentioned to you, Risto, about the numbers. So when I started with this in 2005, I went to the clinician, to the hospitals, to tell them about the international studies of adverse events and the amount of adverse events. And I showed them the studies between 3 and 16%, and they said to me that, but this is not Norwegian studies, so we don't have this problem in Norway, or we don't know how it is in Norway, and you cannot compare Norway to other healthcare systems, and that's why we maybe don't have this problem. So that was in 2005. That was the common way that I was met when I was out talking about these issues. And then in a 5-year period, lots of things happened, and they actually then in 2010 found out that they would do this journal record review study with the global trigger tool measure. And here you see that in 2010 in Norway, in all hospitals, 16%. So we were like in the upper part of what the studies showed. And there you can see that they also calculated the number of deaths, and that's what sparked all the discussion, because the hospital did not agree with the numbers for the deaths. And that's because deaths are rare incidents, and so the numbers are too small to be perhaps statistically viable, at least in Norway, because we're a small country inhabitant-wise. And so then you see in the 2012 numbers, the deaths are taken away because of the massive critique and the posters where the hospitals went into their own hospital systems and studied all the deaths and said that this is the number of deaths, and only a couple of % of the deaths are preventable, type of arguments. And so from 2010 to 12, we went down to 14%, and in 2014, I think it's maybe 13%. But again, the numbers are not more than an indication, but maybe the government and the hospitals try to use it as a way to improve. And of course, the media, as you see here, that's a Norwegian, they are concerned with the deaths. So they say 4,500 deaths a year. What should we do? It's a disaster. So the media love to talk about the dead. And then, following from this 2010 effort, in 2012-13, we got the first white paper on patient safety in Norway. And there you see that they use also the pair of concepts, quality and patient safety together. And alongside this new white paper, or just before the white paper, we had a campaign, a patient safety campaign, a 3-year campaign, which is very popular in many countries. And this has now been followed by a more fixed patient safety program starting last year. And also at the governmental level, they are very interested in effectiveness. We're talking about effectiveness. So the clinical evidence-based effectiveness perspective is forming the grounds for the governmental efforts in Norway, and that means that they are looking for improvement areas that they know it's evidence for different measures. And that means again that the primary care is lacking even more behind, because the primary care doesn't have much evidence-based studies. So it kind of means that the governments are just searching for where's the evidence, and that when they don't find evidence in the primary care literature, they just go to the even more to the hospital-based literature, and then there's even more efforts towards hospital. So even though primary care is now part of the patient safety program in Norway, there's a lack of focus. It's a delayed focus in primary care. And so here's the national patient safety program that I mentioned. And I'm in the board of this program, and when they came up with this vision to become world leading, I was kind of, okay, knowing what I know, how far other countries have come, I wouldn't maybe suggest this vision, but they put in can, but we can. So it's not we shall, it's we can become world leading. But then again, you cannot say that, okay, let's settle for number 10. Let's be number 10 in the world. So I guess for a vision, that's the way it has to be. And then finally, for the rest of, if I can use 5 more minutes, I would give you some examples, and then I would choose the topic that's closest to my own research area, and that's the organizational and cultural factors. And then I will give you a few examples from a PhD work on safety culture, and that's the work that Kaja was mentioning yesterday, where healthcare were compared to petroleum, and then also a EU project that we had for 3 years. So here is the 11 dimensions, very common dimensions of patient safety culture. You might know it is from the hospital survey on patient safety culture. That's an international, American-based international instrument that has been validated in different countries. And this is the hospital version, but they also have a similar version for nursing homes that has been also validated in some European countries, for instance, Switzerland, and it's now being validated in Norway. But here you see it's the common areas of management, both department and hospital management. It's teamwork, communication, manning, collaboration within departments, across departments, reporting. So it's trying to cover all important areas of patient safety. And here I'm sorry that I realized yesterday that there is the Norwegian text on the dimension, but it's the same 11 dimensions such as you saw on the other slide, and it's a longitudinal study from 2006 and 2008, and 2006 is the blue and 2008 is the yellow, and what comes out, or the results, is good if there are 70% or more, then it's reckoned as a good result. And then the medium result is around 40–50%, and then it's a quite poor result if it's 30% or below. And so the poorest results is the hospital management support for patient safety culture, and that's very common because healthcare personnel like to give the blame to the hospital managers on the top because they never see them or they're not satisfied with what they are doing. And then the best results at the bottom, that's the department manager. So healthcare personnel seem to be very satisfied with their own department manager. And then reporting of adverse events is poor results and collaboration across units. And there is the non-punitive response is good, and teamwork within department is good. And so you see the difference between 2006 and 2008 is very small. So there's almost no significant difference between the two years.
If you compare to other industries.
If you can compare to petroleum, for instance, the scores are generally lower on all dimensions. And if you compare to the American reference database on this instrument, it's lower on 9 of 11 dimensions, and it's better on these two. And that's the non-punitive response, because the American has a completely different system. And also this one, I think, is the department managers focus on patient safety is better than in American reference database. Yeah. And the only difference, the significant difference, is that the good dimensions are even better in 2008, but the poor dimensions are poorer in 2008. That's one result that we saw. And this wasn't a study that was designed with an intervention. So this was just a longitudinal study to see if something happens in 2 years. And the hospital, of course, did do several things in the 2-year period. They introduced a reporting system for adverse events. They had like safety on the agenda of leader meetings, and they had what else? They had quality coordinators appointed at all of the clinics. So they did measures, but those measures didn't seem to have an effect on the perception of patient safety among the healthcare personnel. And then many say that, oh, that's normal because you cannot affect or change a culture in 2 years. But there are similar studies in other sectors that shows a significant improvement in short time, like in 1 year or 2 years. But then you have to have the resources for really. It's like the oil industry when they decide that they will have a huge patient safety program, and they take out all the employees from their work for 2 days and just put them in training, or they have lots of resources, and then they actually see a difference. And then you can say that this is old data, 2006 and 2008. It's many years ago. It's when we started the work. And then we have, for some reason, they didn't want us to come back in 2010 and 12. And I guess that's understandable. We've done the study on other hospitals, like in 2009 and 10, we did it in a very small sample among operational personnel, and then we found that the results were as close to identical as it could be with our earlier results. So this is a study that was concentrated on the checklist, the surgical checklist. And Arvid found that introducing the surgical checklist had no effect on the patient safety culture, but he found an effect on morbidity and mortality. And then we had the Quasar European study. I'm just going to skip this one. And here you see a similar set of dimensions for quality, a bit more generic than the patient safety dimensions, but still it's 6+2 dimension. It's many of the same issues, but it's more generic than the patient safety dimensions. And these are the dimensions that we used to analyze our data. And in this study, we had 2 Norwegian hospitals, one rural and one city. And what we found was that in the period between 2010 and 2012, all the participating hospitals had a very structured approach to patient safety. So now there were like routines, there were systems in place, they were working with it in a systematical way, and they were following this formal and rational approach to patient safety, dominating over more informal processes. And the measures are highly driven, at least in Norway, by external factors. So when the government says that every second year you should measure patient safety culture using this and this instrument, you should report the global trigger tool data back to the knowledge center, this is what they do. So they concentrate on what the government says that they will do, and then not so much on their own needs. What are our health problems and how should we proceed? The differences between our hospitals are cultural and political. I will show you a bit about that. So one of the hospitals were chosen to the study based on a high performance perspective. So we chose it based on how the results of the national quality indicators in Norway. So every hospital had to report on quality indicators, and we choose it based on their results as very good over 3 years on different sets of indicators. And here is the picture with these 8 quality dimensions. And you see that there are differences. So you cannot say that a hospital is high performing on all dimensions. It will vary. They will be good at some and not so good on other dimensions. So this is a small rural hospital, meaning that they had problems with setting aside resources and getting people to stay there with high competence. They tend to want to move to bigger hospitals because it's a more qualified people there. And you see the other hospital were selected based on being a medium performer. We couldn't call it low performer because then no hospital wanted to participate in the study. So we call it a medium performer. You see the picture is quite different from the first one. But still, it's not medium performing on all dimensions. It's medium on some, good on some, and not so good on others. And that's why it's the same when we talk about quality. We shouldn't talk about quality like in general terms. We should talk on the specific issues that are at hand. And so here's just the two hospitals taken together. So our study gives a more nuanced picture of this than the scores on national quality indicators. Yeah. And of course, we like to compare ourselves. And here you see the pink. The pink line is the average of the 10 European hospitals that were part of this study. And so in this view, we can maybe say that Norway is among the best. But then again, the average doesn't tell you so much of the results. I'm just very quickly going through this because the time is is running out. So this quasi study, we would say that the factors influencing quality and safety in our study was the size of the hospital. So the bigger size hospital is, the more difficult it is to get a unified and good way of working with patient safety and culture, because we have many subcultures and many different clinical groups pressuring towards what's right. And the competence issue is important, power issues. We saw differences like in the smaller hospitals, the management that are good, they get the entire hospital to work in the same direction. Well, whereas in the bigger hospitals, you have stronger, maybe clinical groups that is exerting power. And also the physical and technical infrastructure is important, like in a smaller hospital, they're more concentrated, like the buildings are located very close or even in the same building, whereas the bigger hospitals might have more transitions, like for instance, the maternity services is separated from intensive care for babies, so they have to transport a newborn baby to intensive care, and that's a risk. So these are also issues that's influencing. So I'm going to stop by saying this, which is obvious, I don't have to say this. Yeah, because we were talking a bit yesterday on the dinner about should we learn from other sectors and I think that I would agree with this Norwegian white paper that came, which says that maybe we should learn more from other countries, from the way of organizing and conducting patient safety and quality work in other countries than in other sectors. And I think maybe that's wise. So healthcare has been very interested in learning from aviation. So there's been lots of studies comparing healthcare and aviation and the way the culture works, and I'm not that sure whether that's very fruitful. I think it's better to compare with other countries and other healthcare systems and context.
So that we've learned from the other cultures what there is to learn. I mean, taking most of the things on board now.
I know we haven't, and that's because healthcare don't want to do that, because they say that they are special, and maybe system-wise, as we said yesterday, you can learn something from the systems that they use, but that's just one leg. So you needed another fundament of your work, and I think it's now there's so much progress in different countries on patient safety and quality. So I think that there is things to learn from other countries, at least for us in Scandinavia. I think I will end by saying, okay. I'm sorry about the time, but
I think this comparativeness is very good, and I think we should learn from each other's, not depending on the disciplines, but sometimes, for instance, in information system implementation, we have learned that when a library takes a new information system, they close the whole library. But we can't close the hospital.
No.
And that is same in patient safety, that if there is a lot of turbulence or some kind of tornadoes or whatever, they don't fly. But if there is a turbulence based on too many patients in the acute care, we don't close the acute care. We just try to cope and do our best.
Yeah.
But of course there are certain processes and that kind of thing that we should be more careful and check different kind of things and discuss with each others.
Yeah, but there are ways of learning how to cope
Yeah.
with extreme pressure or extreme patient load, or there are certainly ways of organizing that work that would make it easier than just trying to cope without having thought through that scenario in advance, because you can do lots of preparation for that situation by using it as a scenario. And we use scenarios in hospitals in a completely other way. We use very small and nice scenario. The trauma teams use a complex scenario, but it's only with one patient. It's with the trauma patient, which is complex, extremely complex, but it's one patient. But we don't set up our scenarios with the emergency room overloaded and what do we do, and with the logistics, and we're not that good, I think, with setting up those kinds of scenarios.
As you said, the culture may be better in small hospitals. That would mean that bigger hospitals would have to invest more in patient safety or care.
Yeah, and I'm not saying that it's possible to create one culture. That's not because that's a difficult notation to use. But you need to make sure that the different subcultures are not fighting against each other to hinder progress. You need to make sure and put enough efforts into trying to get the different subcultures at least to work on some sort of the same way. And that requires much more effort in larger organizations, and it's a trend. We make bigger units in all kinds of societal work. We merge airline companies, we merge hospitals, at least in Norway. So it's this trend of always making larger units has consequences that we need to be able to think through and to plan for, and I feel that that's lacking in healthcare. For instance, in the petroleum, when they merged the two largest companies in the around 2000, then the government said that we will have to follow this from day one and before. And they have all these kinds of meetings with the Petroleum Safety Authority, goes in to supervise, and they have to report to the authority. But in the healthcare, when you in Oslo, we've merged 3 large hospitals in the capital into one. The process was just boom. Then there seems to be no good way of planning those processes. It's just a decision that comes from the blue, and then we will do it.
Yeah.
Well, it's just more of a comment. We actually went through a process of merging. So in Canada, each province is separately responsible for their own healthcare. So a lot of the provinces have regional health authorities, but the one that we've been watching in the last couple of years, just to get an idea of what the implications are, is Alberta. Alberta is the size probably, I don't know, Sweden or Finland. It's got one health authority.
Yeah, okay.
That's it.
Yeah.
And the argument for it was that it results in cost savings. Because you have one health information system for the entire province. You have one way of doing things. You have everything centralized that you can centralize.
Yeah.
So, but the problem is you take away local innovation, where you can take it away by doing that.
Yeah.
So there's drawbacks to it.
Yeah, of course. And it's very interesting
But it's that whole notion of standardization, so standardization equals efficiency, effectiveness, and quality versus localization, right?
Yeah. Yes, and the same goes for centralizing specific clinical specialties, and they say it's about volume. So volume is related to quality. The more operations of a specific disease, the better quality. But there are studies coming out now that shows that there is not a direct relation between quality and volume. But the government seems to use this volume argumentation for quality. Yeah. Okay. Thank you very much for listening. I'm really happy to.
Thanks very much for coming.
Thank you.
This was really interesting.
Thank you.
And I hope we can keep your slides and show them as our role.
Yeah. Of course. Okay.
Ja,